Okay, everyone, so we're going to get started. I welcome all of you today to our Family Leadership Network, Family S.H.A.D.E Learning Community. I thank you all for attending. We are recording now. We like to make these videos accessible for any families or professionals that are not able to attend in person. Those of you that are here in person, or virtually rather, you'll see that there is a survey up on the screen. If you could please complete that. That's how we're able to gather information, share it with our speakers, and share it with our funders as the Parent Information Center and Family S.H.A.D.E are nonprofit organizations. So I'm going to keep this up for a few more minutes, but in the meantime, I would like to welcome you all, and in particular, our presenters that are here today from Newcastle County Police Department's Behavioral Health Unit to talk about the Mental Health Unit and the program. So if you could, Andrea and Corporal Kearns, would you introduce yourselves and just share a little bit about your background?
My name is Andrea. I'm one of the social workers with Christiana, embedded in the Newcastle County Police Department. My background is primarily working with youth and their families. I've worked with the state of Delaware in many capacities, including Division of Family Services, Family Court, the Attorney General's office. I've also been a home visitor with Children and Families First. I worked with Mobile Crisis through Delaware Guidance Services, and now most recently with Christiana Care, as I mentioned, a social worker embedded in the Newcastle County Police Department.
Good afternoon. Corporal Colin Kearns with Newcastle County Police. I've been an officer for 21 years, the last 5 years with the Behavioral Health Unit. Do have my MSW from University of Penn. I'm currently assigned as a co-responder. So I work in the police car, and my partner is a social worker, and our goal is to answer 911 calls that have a mental health component to it or a addiction component to it.
Okay, so for those of you that were sharing before we get started, we posted the pre-QR code on the screen for a couple of you that were all registered under the same name. If you could go ahead and answer that, I would greatly appreciate it. I will leave that up just for a couple of minutes, but Andrea and Corporal Kearns, thank you for sharing your information. We greatly appreciate it. If we could start by just introducing the program and what you all are doing in the community right now for families and members of the community that identify with a special healthcare need or mental illness.
Sure. So the Behavioral Health Unit has two different sides to it. We have addiction and a mental health side. So Andre works on the addiction side, I work on the mental health side. Just a quick overview of the addiction side. Anybody that overdoses in Newcastle County, within 2 days, a nurse, a mental health professional, and an officer will respond out to the community, to their house, wherever we can know where they're staying. So sometimes it's out in the community, sometimes it's at their home, wherever the address was for the 911 call, and offer that person treatment free of charge, case management, Narcan. We also have the Tetera bags for medication that we leave at the households. The other part of the addiction program is officers out on patrol can offer, in lieu of arrest, treatment if the person identifies as someone that is suffering from substance abuse disorder. It doesn't mean that they don't get arrested, it just means that the warrant pens, and if they complete treatment, the warrant goes away. If they go to treatment and they walk out against medical advice, and we don't say what that medical advice is, the treatment providers do, they just give us a 1-page progress note. Hey, they're still in treatment. Hey, they're not in treatment. and the reason why they're not in treatment. If it's medical reason, we'll still work with them. But if they walked out against medical advice, then we reactivate the warrant and they're arrested for that charge. So that's the quick overview of the addiction unit. We also have people that can call in and ask us to go check on their loved ones. So if someone says someone in my family's in addiction and could really use some support, they can provide us the name and address, and our team that does outreach twice a week can stop in and see if that person's interested in treatment. So the other side of our team is the mental health unit. So the mental health unit, there's 3 teams of co-responders. So that's an officer with a social worker. Currently in the process of hiring the 3rd social worker. So right now we have 2 teams up and running. 3rd one hopefully be up and running by the end of this month. And then we have a case manager. So the co-responder jobs basically are to answer 911 calls that have a mental health component to it. So you have both the officer and the social worker responding to the house. All officers in the mental health unit are CIT trained. All officers of Newcastle County get 2 days in the Academy of Mental Health training. So that's de-escalation, autism awareness, mental health first aid. So every officer has a working knowledge of mental health, but the CIT is a 40-hour course that's offered to officers with 3 or more years on the force. So why we offer the crisis intervention training with 3 years is that we want officers with a little bit of experience of what's going on out there. Teaching it in the academy doesn't make sense to us because they don't even know how to be an officer yet. So 3 years on the road, they're through their FTO. CIT stands for Crisis Intervention Training. So 3 years on the road, and they kind of have like they know what it's like out there. They know what calls they're going to answer to. So it's completely voluntary. It's a 40-hour class. NAMI Delaware puts it on. A lot of our officers teach in the class, and it kind of dives in a little bit deeper into mental illness, de-escalation, institutionals, what's it like when somebody does go inpatient? How do you connect people to outpatient resources? And then after CIT training, we also have VRT training. So that's a veterans response team. So officers that are veterans or count military can go to the CIT and then to the VRT training. So that's 3 extra days after CIT to get more specialized in how do you deal with veterans in crisis. So for me, I'm not a veteran. So when I go out to veterans, when they're in crisis, I don't know the language that they all speak. And I know it makes a difference because us as cops, we talk in 10 code, we talk our own language. So having someone there that understands you really makes a difference. So we encourage all of our military personnel to go to CIT and then go to the VRT so we have more officers available for our veterans that are in crisis. So I'm going to let Swan kind of talk about what she does as a child victim advocate because she kind of works in the middle, so on both sides.
Yeah. So like Corporal Kearns was saying, I kind of have a dual role within the unit. So with our like addiction side, I work with any youth and family members that are affected by the parental substance use. So that's getting them connected to any resources as a result of what they may have experienced having a family member or loved one, maybe not in their lives or, not available due to their substance use. And then with the mental health team, so the co-responders, any referrals I get from our team or patrol officers who respond out to youth in crises. So that could be anything from like a mental health crisis to behavioral issues, such as like parent-child conflicts, runaways, criminal justice involvement, things like that. They will then refer to me and then I case manage them. So I typically try when I get a referral during the week, I try to call the family at least within 48 hours. Just to let them know, I kind of give them a rundown of who I am and why I'm calling. I really like them to know that I'm here for you. I'm checking in. How can we best support you? How can we reduce these calls to 911? And how can we get your family connected to services? So I do kind of my own assessment. I dive a little deeper into what the family and the youth have going on, what has worked in the past, what hasn't, diagnoses, medications, insurance, any type of social determinants they have, lack of transportation, financial insecurity, housing insecurities, anything that may be affecting family and youth as a whole unit. I try to tailor my referrals and treatment plan around that. So I will case manage. Sometimes I work with families, sometimes up to like 6 months, because of different barriers. But once I know they are connected to care and I can verify that connection, such as they've made an appointment, they've gone to their first appointment, they feel comfortable, then I will close them out. So my caseload can vary, depending on how many referrals I get, how many of the families feel like they are okay, they can advocate for themselves and their children, and then I will close them out. And once they're closed out, I don't typically do any follow-up. Sometimes I do have families reach out to me for more resources, which I leave that door completely open to them. I encourage them to call me, should that need arise.
Thank you. So we do have a question in the chat that leads us to our next topic, but what does it look like when this unit receives a call for a child or a family that has a child with a special healthcare need that is in crisis? When you receive that call for a child, what does that look like?
So all 911 calls, we try to do what we call like premise history. So we look up, have we been there before? What resources are already in place that we know about um, as we're driving there. And then once we get there, the child is in crisis. We really look to the family, to be honest, because we walk into your life for like 15 minutes. You've been with this child, you know what's best for them. So once it's safe, like the child's not a danger to themselves or they're not hurting themselves, we kind of sit down and work together with the family to see what the next steps would be. Should this child go to inpatient? Should they be here, stay in the house with bringing like a caseworker or child mobile crisis out to the house? Every call is a little different, so it's hard to say what's exactly going to happen, but the social worker does their evaluation and works with the family and um, coming up with together of what the next steps should be. A lot of times I know everybody, it's a crisis, it's heightened, it's up here. And then when we walk in, they want us to know the answers. And I'll be honest, we don't always know what the next steps are right away. So we could be with you for quite some time. It could take us a few hours to figure out what the next right steps are. So obviously if they're homicidal or suicidal, well, that's an easy one in the fact that we know that that person needs to go inpatient. And if it's a child that's going inpatient, wherever we're going, one of the parents or guardians have to follow us there. So if we're going to AI, Meadowood, Rockford, Dover, Sun, the parent has to come with us and sign your child into care there. If it's adult, it's a little different. If they're homicidal or suicidal, obviously we'll write the 24, we'll take the person to care. But as an adult, they can refuse to go to a hospital if we don't have enough information or enough to put them on a 24. But for children, we have a little bit more wiggle room to work with the parents, to work with the schools, the social workers that are already involved to get that person connected to care. As long as that child is safe, We don't want them to go inpatient. We don't want them to go to the ER. We don't want them to miss school or family life. So if we can keep them in the community, we can keep them supported. We can come up with a good safety plan. And I always say we, but I'm going to be honest, it's really the social workers that do most of this work and the really good work. Me and my officers work on the crisis, the de-escalation that's going on at the time, but the social workers are who dives in to set up the next steps and work with the families on connecting to care. I just get to present, and I end up taking credit because I keep saying we all the time, but it's our social workers that work in the unit, and they're all Christiana Care employees. So they have the Christiana Care network, but they work with all hospitals. And I did see the question about autism. So for Newcastle County, we do teach autism awareness in the academy. It's a 4-hour class, and we are not teaching our officers to diagnose. We are just teaching them these are signs and symptoms that somebody that you're working with in the community could be on the autism spectrum. So we go from the nonverbal autistic person to the very high functioning, and some of the characteristics that you might see someone that on the autism spectrum have. So we go over what stimming looks like, what meltdowns look like versus tantrums, that kind of thing. And then we provide the officers with resources to provide to the families. Most of it's like Delaware Autism Help is here, Delaware Help is here. And then we tell our officers to refer to our unit, the behavioral health unit. So our case managers can follow up with that family if they're not already connected to care. So when I say child versus adult, adults are anybody over 18. So they could be in high school, but if they're 18, they're 18, and under Delaware law, they're considered an adult. A child, and anyone under the age of 18, where it gets a little dicey is when they're 14 and they're like refusing meds, and their family calls us because they're not taking medication, but under Delaware law, they're allowed to. So when the family calls us, there's not much we can do with that other than connect to care and kind of support and educate the child and the family, and hopefully work with them to understand their medication, and maybe they'll start taking it, or maybe we can figure out why they're not taking it. But that's not a reason that we can put a child or an adult on a 24-hour detention. So it has to be not taking medication and a behavior that a reason why we could take somebody out of their house against their will. I don't know if I missed anything there, Swan.
No, that was great. Thank you. So one of the things that was really perfectly brought up was that difference between a child and an adult. So with Family Shade, we're oftentimes talking in the community and sharing with families that transition to adult healthcare. So what that looks like, moving from being a quote child to a quote adult. Something that we talked about last night that I think was a really great resource that you shared, and I'd ask that you share it again, is what are some ways that you may try to share with a family or give them information to support their child that either has a mental illness or has been in crisis in the past, but is starting to move from that child age to adult age? What are some resources or ways that they can kind of care plan that you would share with that family?
So we always talk to families about let's not plan for the crisis while the crisis is going on. Can we have a crisis plan in place prior to the crisis happening and get everybody involved in that? So the person that you're caring for that has the mental illness, what's their expectation? So they're in a crisis. What are the things that are going to happen? We're going to call 911 when you get to this level. We're going to call your case worker prior to, and then ask them of like, how do you de-escalate yourself when you're in this crisis? And then when we get that information, we encourage the families to go on our website. And it's Newcastle County Police Department. go in the search engine in there and look up Smart 911. So Smart 911 for us is that you can give us any information about yourself, your address, that if you have to call 911, the officers, the medics, fire, knows whatever you want us to know. So what could that look like? That could look like, hey, I live at 123 Main Street. I have a child that's in a wheelchair and they live on and their bedroom's on the second floor, front bedroom. So anytime that we go to your house, we know that information. Or it could be my child or I suffer from whatever you want to say. And here are some of the triggers, please don't talk about. And here are some de-escalation skills that have worked in the past. So one of the best examples I have is that we work with an adult autistic male who lives in a group home who is somewhat verbal, but when he's in a crisis, really loses his verbal skills, but he loves Raven football. So we put that in the Smart 911. So it's set, so any officer at any time responding to his residence says, please talk to him about Ravens football to help de-escalate. And then it also says that please talk to him in short sentences. Say, please say stop, drop what's in your hand. So a lot of times it's drop the bat, drop the rock, and then sit, and then give him time in between to answer those. So it helps any officer go out and respond. Prior to having that in our, we call it premise history, but Smart 911, we were using force on this gentleman like 2 or 3 times a month because he's 6'5", very big man, very violent towards his staff when he's in a crisis, but he loves police. And since we had that information, hey, we're going to talk about football right away. We're going to use very short sentences to talk to him because he, looking at him, you wouldn't know that he had anything cognitively wrong with him. So officers that never met him before would talk to him very fast and very direct because he had a baseball bat in his hand and he had different things. So having that information prior to us coming to the house really helps us plan how we're going to respond. And then we talk to families about how do you call 911? It seems kind of an easy thing to do. You just, press 911, but what information do we need? We need to know who you are into relation to the person in crisis. I'm the parent, I'm the sister. Where are you in the house? Are you safe? And then we see a lot, almost every day I'll see something like, hey, my loved one is having a mental breakdown. Okay, what does that mean? We need to know the behaviors. So they're hitting their head against the wall, they're screaming and yelling. What are they doing? And that made you call 911? Like, and is there anybody in danger in the house? So we have all that information going while we're en route to you. That can really help. And then if it's to the point that the person is being dangerous against, even if they're just throwing stuff, can you get yourself outside the house and wait for officers out front? And does the person know that we're coming? Because sometimes people will call 911 and their loved one's not aware that police are en route. You can still text 911. That is an option.
We have another question, Corporal Kearns, that came up right above that. Patrice says, what happens when all and or majority of these resources or suggestions fails you? Or you feel as though you're just getting pushed to the side?
So I'm guessing you're speaking you as the parent or you as the person suffering from?
Both.
Okay. So you as a parent and it's a child under 18, I'd really encourage you to talk to one of our social workers and help them advocate for you. So kind of work as a team to see why you're getting pushed to the side, and maybe we're not connecting you to the right people. So expressing that you feel that way would really help, because we connect people to resources and we think you're good, and because we don't hear from you. Sorry, my CAD, people want us back on the road as quick as possible. Um, but so expressing that to us as the behavioral health unit that you feel that way. I'm gonna tell you that the system is tough. It's very tough to navigate when you're well. So I know that when people have mental health crises, um, it has to feel even more overwhelmed. Our social workers are great on, okay, this one didn't work for you. Let's go to the next one. And I kind of always tell people that I work with, like therapists are like running shoes. Like they might fit and they might really feel well for a while, but if you're sometimes you might need to switch it up, or it's not a one size fits all. You got to keep trying it until you find the one that works for you. And in all kinds of treatment, like group therapy might work for you now, but it might not work later, and you might have to switch it up. So it's communicating and not giving up and asking for help, because I I depend on my team for a lot of this. I know some stuff, but I would say they're more the experts than me at this. But feeling pushed aside as a parent when they're under 18, um, you have a right to that information. You're still their guardian. But as soon as they hit 18, you're going to feel pushed aside, because it's up to that adult if they're going to sign a release for you. And I always encourage people with mental health, that go into crises and that know, like, hey, why don't you sign a release when you're well for your treatment? But it's up to that person if they want you to know, and we can't make them. We can always encourage them that, like, hey, that's your support system, that's who you're going home to. Shouldn't they know what's going on too, so that they can be part of your safety planning and your planning after the hospital? But it's up to adults. It is very tough when they
When I
when
say
that's
push to the side, I mean more so like not getting the help that's required, I guess, in that sense.
so when you call 911, or when after 911.
Both.
So when you call 911, it's really tough for police officers. There's a limited amount of things that we can do at that time, and there's also insurance issues. So I would defer to the social workers on how to get more access to care than police officers. And a lot of times, if it's not right there, they're sending referrals to our social workers to follow up with you then the next day. Um, I know
And if
Delaware,
none of that happens, then what?
if the social workers aren't following up, or you're not,
Never get connected with one.
you've I mean, I can talk to you afterwards and
That's fine.
see how we can connect you, because I don't know what your situation is, and I don't know what kind of help you're looking for or your family's looking for.
Mm.
And I do know that the Bridge Clinic is also a really good start for people who feel like they need help now. And the Bridge Clinic, it's 14 Central Avenue. It's right behind the Terry Center. They're open 24/7. You can go in, walk in there anytime, sit down with a clinical social worker, get the assessment, and then they can connect you to their in-house doctor if any medication is needed, or they can start with in-house therapy and then refer you out to outpatient, because I know, especially with kids, that, there is waiting lists for therapists and finding that. So the Bridge Clinic might be the best step now until something opens up in the community that would fit your need.
Okay. Thank you.
Um, Thank you, Patrice. That is a good segue. Andrea, Corporal Kearns mentioned that families can also reach out directly to the social worker. And as the child victim advocate and one of the social workers on the team, would you be able to share with some of our families and the professionals that are on the call today, what that process looks like of a family that reaches out directly to you, either just looking for resources or after experiencing a crisis situation?
Yeah, so um I get my referrals from like community providers, self referrals, patrol, anybody within the department, so victim services, detectives. And then once I get the referral, I always take a look if there is a police report just to get a general idea of what the situation entailed. And then when I do the call, I always have like a set of questions I always ask. Oh, I like to get like background information. So that can include any history of treatment, any history of medications. And I really like to know what has worked and what hasn't worked, because sometimes some youth don't do well in like one-on-one therapy sessions. Sometimes they like groups. Sometimes they need something like intensive outpatient. Sometimes they need residential. It really depends on what's going on. Sometimes I do kind of skip all that and I give parents information for like youth empowerment programs. So one of them I like to utilize a lot is a program called Gloves Against Drugs. It's a free boxing program in the city of Wilmington. It's like youth mentorship. It kind of builds a camaraderie with different youth coming from different backgrounds, different experiences. And it's just a really positive outlet, and it's something that they really look forward to. It's in a controlled environment, helps a lot with my kids who have like behavioral challenges, especially like anger management. It's a good way for them to kind of let that out. So it really depends on what the families have going on. And again, going back to kind of my social determinants, if there's any barriers, I like to also try to tackle those a little bit, because that can be stopping the parents or preventing the parents maybe from doing follow-ups and the phone calls because they have other things going on, like financial issues, housing insecurities, things like that. So unfortunately, when their youth is in crises, sometimes they can't make those phone calls. So I tried to help them in any way I can with, getting those services in place as soon as possible.
Thank you.
Mhm.
Before we go further with that, you mentioned something that might hold parents up from being able to make the call. And I think some of that is understanding the crisis.
Mhm.
April asked a great question that moves into this piece, but could you talk a little bit more about the role of mobile crisis? And Corporal Kearns, you did this really great yesterday as well, but explaining when to call 911 and when to call mobile crisis and just making the distinction between the two.
Sure. Mobile crisis is more prior to 911. So you start noticing that the person is declining. Um, you know that you're on the road to possibly a crisis. That would be when when you should be calling mobile crisis or 988 and trying to get that preventative care in there as soon as possible. They stop taking their meds, they're isolating and they're not eating, they're not sleeping, but they're not in a crisis where you need 911 police services yet. That would be the best times to, call their social worker, call their case manager, call their behavior um, support systems. And then if you none of that's set up yet, then that would be juvenile mobile crisis or adult mobile crisis services, so that they can have one of their crisis teams come out and sit down and do the assessment prior to waiting for the crisis to happen. Um, they are 24/7. They do go into the community when their teams are available, and sometimes they talk to the people over the phone. So if your loved one was like, absolutely not, don't send anybody here, but maybe they're willing to talk on the phone. So prior to calling 911 when they're violent, when they're in such a place that they need inpatient, mobile crisis and adult and juvenile mobile crisis would be the best bet from there.
Okay, thank you very much. I appreciate that distinction. April, did that answer some of your question between the role of mobile crisis? Great. Something else that we spoke about last night at our FLN specific training was some of the resources that exist in the community for families and children that are going through a mental health crisis or before they go through a mental health crisis. Andrea, would you be able to share some of those resources again, as we've got some new parents and professionals that are here today? Just some of the resources that exist in the community to support the cause that may be able to help children and families as they go through this.
Yeah, so again, depending on what the family has going on, I do provide outpatient and therapeutic supports pretty much with every referral I do. Again, it depends on like insurance, location, things like that. But I also always include a crisis text line. So that's 741-741. And I like that one because majority of youth have a cell phone and they like to text. So this is a text line. So they don't have to speak to anybody over the phone. They can text them. And it is like a 24/7 response. So somebody is always available to talk to them. I always include Youth Mobile Crisis 1-800 number. And the two other ones are Mental Health Association in Delaware and NAMI Delaware. And I really like both of them because they have a lot of really great resources for parents, especially on understanding specific diagnoses, how to best support and advocate for their child with mental health. Really great educational resources, wellness groups, trainings, classes. So those are the ones that I typically refer to the most, just because the amount of resources are just bountiful there. So those are the ones that I include and provide to all the parents.
Thank you. Sorry, everyone.
Mhm.
I'm just trying to go through and add these as they
Mhm.
come up.
Mm.
Um,
And I can
So
always
I do want
email
to
them
say,
to you,
oh,
Jaleesa, also.
okay.
the one thing that the social workers put out is the NAMI organization, and they also do parent groups, but like self-care groups, because if you're
Mhm.
caring for a loved one that is
Mhm.
um, in a mental health crisis or living with any kind of diagnosis, it's draining on you too. So how are you taking care of yourself and taking care of somebody else? So they do both. They educate you about the mental health um, issues, but they also work um, to make sure that you're taking care of yourself, because you can't be pouring from empty glasses out there. It's not going to work for anybody. They also was a great help for our organization when we started wellness programs for officers. And so now we have twice a month a yoga class that is just for first responders. So we are looking internally to make sure that we're also taking care of ourselves and our officers. So NAMI is a great resource for families.
Thank you. So something that we talk about a lot with Family Shade, and some of our FLN members that are on here know, is both the transition to adult healthcare, but also building a medical home. So doing some of that care mapping and being able to pull those resources that are out in the community inside as you start to build that medical home or your care notebook up. So you've shared some really great resources today, but something that you shared yesterday was that crisis plan or crisis planning. Would you all be able to touch on that a little bit more? I want to be able to instill in the parents that are here that understanding of that, but also the professionals that are here being able to share some of those resources and information with any families that they're working with. Are there any specific guides or additional information that you might give someone that is trying to plan, like you said, before the crisis occurs?
So I usually encourage people, if they have support systems already case managers, let's sit down before the crisis and look at that plan, what it looks like, and let's revisit that plan like every 6 to 8 months to make sure it still makes sense and make sure the phone numbers are updates and the care is appropriate for that person. But then for people that aren't connected to care, don't have caseworkers, that kind of thing, um, we you can reach out to the behavioral health unit and we can set up a time to meet with the family when a crisis is not going on, and our social workers can work with the family to put a crisis plan in place that would make sense. And I am not the expert on that, so I would defer to our social workers on what that would look like. But we want to make sure that if we know the plan ahead of time, that everyone's aware of it, that the mom, dad, child, everybody that is a support person knows this plan, and so does the person really have input into the plan so that they understand that there's no surprises. Like, this is what happens when we're in a crisis. We call if we got to get to 911 and you are going to be transported by police, you are going to be handcuffed, you are going, in the back of a police car, and that's our policy. We can't change that. They are not arrested, but they are detained in our custody, so they will be handcuffed so that they're aware of this.
Oh, Andrea, I don't want to cut you off. I see that you're unmuted, but I wanted to ask,
That's okay.
as the social worker, do you have anything to add to this?
Yeah, I think, it, I really agree with Corporal Kearns. I think just utilizing what supports you have in place. Sometimes youth I get on my caseload are connected to teams, with like prevention and behavioral health through the state of Delaware. So I always strongly encourage the families to really advocate for their youth. If something isn't working, you are the eyes and ears. You see your child every day. You see the behaviors at home, at school, in the community. You have a team, utilize them. Some parents don't even know their caseworker's name. They don't know their treatment providers. This is information that the family needs to know. If they don't know, ask the questions. You are the one that has to deal with them on a daily basis. So you are allowed to, let them know really what's going on. And I think also, like Corporal Kern said, like being as proactive as possible, what works for them. If they're escalating, don't push back. Sometimes I need to tell parents you just walk away. Give yourself a few minutes. If they're safe, let them go for a walk. If they want to go outside and take a breather, let them take a breather. If they like to draw, journal, whatever it might be, just sit down and have that conversation with them. I did have a referral a few weeks ago. The mom called just with concerns because she found concerning drawings and writings of her daughter. She wasn't actively suicidal, but she has a history of like self-harm behavior. So she is connected to a therapist. Mom wanted her to possibly go inpatient, but she really didn't meet that criteria. So we came up with a safety plan. And she sat down with her daughter and they created it together. I said, she's old enough. Just ask her what's going to work, what doesn't work. So they came up with something very simple. Like she has to keep her doors open. Mom took away all the sharp objects. I gave mom a couple medication lock boxes that I get through the state, things like that. And just really opening up that communication so the child also has a voice and say into the treatment plan or safety plan moving forward. I think that's really important. Just really that open communication, I strongly encourage.
Thank you. I see that we have another question, and hopefully our presenters will be able to share some information on this, Jamie. But how do you put a crisis plan in place for a child 14 or older that refuses needed meds or care? Do you have any suggestions around that or how you've approached that in the past?
So if they're refusing medication or care, there should be a time that you could sit down and be like, okay, you're refusing your help, you're refusing everything we give you. These are your expectations of your behavior. If your behavior doesn't meet what's expected for that household, these are the consequences. So it could be, if we have to call 911 and you're 14 and older and you just hit mom, or you're pushing people, or you're throwing stuff and you're a danger to others, it's not going to be the deferral from arrest. It's going to be, you're going to be arrested. We'll put you in mental health court, and it's going to you're going to have to go through that process because you're refusing to care for your mental illness. You're refusing help. So you're going to have to be court ordered for help. But if you can stay within the maintain of whatever the household is, whatever the behaviors that you want from your child, letting that child know that this is what expected of you, and these are the consequences if if you're not meeting what's expected. But I know it's easier said than done, and I know a lot of this is tough. But if you need help, the social workers are here and can talk you through the process of what that looks like, or put you in touch with somebody else that would be more specialized for your needs.
Yeah, I come across this quite often. I think what I have seen work is finding somebody that the child is willing to talk to. So again, that might not be a therapeutic support. It might be a school teacher. It might be, I've used like football coaches before, soccer coaches, somebody where the child was willing to open up. Why are you not taking your medication? Sometimes they don't like the way it makes them feel and they're not able to verbalize that. So maybe it's all just a medication change. Sometimes, unfortunately, some children are misdiagnosed. So let's get a psych eval. Let's see maybe what's going on, a misdiagnosis, things like that. Why are you, let's find out why they're acting out. Why are these behaviors occurring? So I think finding a mentor or somebody that the child trusts, because sometimes, unfortunately, they don't always open up to the parent. I've used siblings before, aunts, uncles, whoever they're comfortable speaking to, maybe trying going that route and seeing if that helps them open up a little bit and just asking them really what's going on. What can we do for you to make things better so we don't keep going down, this spiral and we don't want to call the police every time. What can we do differently moving forward?
Thank you, Andrea. That's really great. Jamie, something else I wanted to touch on because they shared some really great resources that are in the community. But if you feel like your child doesn't have that coach or person that they can talk to, I would suggest reaching out to NAMI. They've got some peer support specialists. That's something that can be really great, especially for like an older kid or a young adult. I know for me at that age, I didn't see anyone that looked like me that was well. And it was like, oh, I just didn't understand that that could be a possibility. I didn't know what well looked like or what well felt like, or what it could feel like. And getting to talk to somebody that had my same experience, that was in that like well headspace, that was feeling better, or was in a place that they would have identified as like recovery, changed my entire mindset because I thought that I was stuck in the place that I was in. So NAMI is a great one. They equip peer support specialists every year. And that's not just something that is for like substance use or alcohol use. Those are also people that are equipped with an experience of mental illness and mental wellness. So definitely, if I can find a contact for them, I'd be happy to share that. Does that help answer some of your questions, what Andrea and Corporal Kearns had shared?
Yep.
Okay, great. So Kathy, I see that you're next. You've got a question that's coming up. So Kathy, I'm going to share the floor, but for all of those that are still attending, I see that we've got about 10 minutes left. I'm going to go ahead and share our post survey as we ask some more questions and keep the comments going. This has been really great. Anybody that is here today that does have to jump off, we'll share both recordings with you so that you can share within and without to families or other professionals that may need or use this information. So I'm going to put the next post survey up. I'm also going to go ahead and share my screen that will show our QR code for the post survey. And until then, Kathy, I open the floor for your question.
Hi. Sadly, there are parents that are abusive and lie. And then also, sadly, there are children who are violent and lie. And so I was wondering, in your training, how do you determine who is lying? And the reason I'm asking is because I'm in a support group of parents. A lot of them won't call the police because their children have threatened to lie about them. I know of parents who have lost their teaching and mental health careers, licenses, jobs, because of false allegations by the children. So how do you determine what's going on?
So it's not easy. We're walking into a house that's probably been dealing with something for 15 plus years, and we're in there for 15 minutes. So it is very tough. And the other point of that is, just because somebody has a mental illness doesn't mean that they can't be a victim of a crime. So yeah, they might be suffering, might be making statements that are untrue, but we do have to investigate all of them, because I don't want them to be overlooked just because they're mentally ill. Um, so it does take time, and it does take interviewing, and um, we look at the history too. Is this something that they do when they're in a crisis, or has this been investigated before? Again, it's not a perfect system, but it just takes a lot of time to figure out. And we use all the resources: past case managers, current case managers, teachers, other family members, to support what's going on in the household.
Thank you.
Thank you. So as we start to finish up, I've shared some of the phone numbers. Corporal Kearns, I also see that you've shared some numbers, as well as websites that were talked about today. Something that we try to do in these meetings is open up the floor for any resources that attendees may know that they can share with other professionals or families that are on the call. Is there anybody that has any additional questions or any resources that they may be able to share today? And you do not need to raise your hand. You can be compelled to put it in the chat if you feel comfortable, but you can also share it out. We did mention that we share out these recordings, so if anybody has any information that they'd like to put out there, please do so.
And please look at the Smart 911, because it really helps us respond better to you or your loved one when they're in crisis. So please take a look at the Smart 911, and whatever you're comfortable sharing with us, even if it's just de-escalation techniques that works in the past with you or your loved one.
Oh, and yesterday, Corporal Kearns, you mentioned that it actually doesn't just have to be for a crisis situation. This is something that all first responders can see. So it could even be that you have a child in the home with a wheelchair on the second floor. That was a great example that you'd shared. You can share that there are multiple children in the home, things like that. And this is something that, correct me if I'm wrong, any first responder that shows up to the call can see.
Yeah, so fire, ambulance, all of us. But what is really good for us too is, like, if you have someone that elopes from your residence, where do they go? Where have they been found before? We have somebody that's on the autism spectrum, that 2 locations that he usually runs to, so we can send people there right away. And we have another person that their father has dementia, and when he walks away, he goes to a certain park and a certain park bench. So it's good for the officers to know that prior to, so we can send one person to the house and one person to the known location that person sometimes goes to when they elope from the house.
Wonderful. Thank you. Oh, I see someone in the chat. Oh, thank you, Kathy. Kathy's saying thank you. It was very informative. For our Family Leadership Network related training, so our learning communities, we try to take topics from our families from within that may be looking for additional resources or information. But we also try to gather any information that's in the community. So please, all of you, feel encouraged in the future, reach out via email. I will go ahead and share our email, and you'll get some follow-up information with our recordings and then the resources that our speakers share today. And then Corporal Kearns Andrea, are you both still comfortable if I share your contact information? I know yesterday you said absolutely. We've got a much larger group today, so I just wanted to make sure, are we still good with that?
Yes,
Yeah, that's
please.
fine.
Awesome. Thank you so much. When we have speakers, everyone, that are like encouraging you to reach out to them, they really mean it. So we know with Family Shade, and just as professionals in the community, parents, and even some of us identify with having a mental illness, the resources out there right now are scant. It is a hard place to be right now, being a person with a mental illness, let alone a caregiver or a child that has a mental illness or has been in a crisis situation before. Um, these two presenters today are encouraging you to reach out to them. So please feel comfortable to do so. I will attach both of their emails in my follow-up email with all of our information from today. So I just wanted to thank both of you. I see we've got about half of the people that have followed up on our post survey. I'll leave that up until we end in about 2 minutes. I've also got our QR code that is up for our training evaluation. That is how we gather even more data to share with our funders, as both the Parent Information Center and Family Shade are nonprofit organizations. And we really want to hear your thoughts. We want to keep the growth going, the capacity building going, and being able to do so from within. So if anybody has any more questions, comments, thoughts that they would like to share, or resources that they're looking for, if you're not able to do it today, please feel compelled to send me an email, reach out to us on FamilyShade.org, pickofdell.org. You can search us, you can find us on social media, and do so with Newcastle County Police Department. We will share both emails, but we want to thank everyone for attending today. And speakers, thank you so much for sharing so candidly. Parents, thank you for being so vulnerable in your shares, and professionals, thank you for coming out today to continue to try to build the capacity to be able to serve our youth with a special healthcare need that are in the community.
And I will say, you don't have to reach out today. You can put my contact information in your phone if something comes up 2 years from now. Anything in the courts, if you might have questions about, you can shoot me an email. We can set up a time to talk. So, save that information. If you want to talk today, that's fine. But if you want to talk 8 months I have 8 years left here in Newcastle before I retire. So from now until 8 years from now, I got you. All right. So just send an email or call.
Wonderful. Thank you both. I am going to.
What's your contact information? I don't see it.
Oh, I was going to send it out after, but if either of you are close to your computers, would you feel comfortable putting it in the chat? Wonderful. Thank you so much. We're after time, so I'm going to end our poll. I am going to go ahead and stop sharing my screen, if it will allow me to. Come on. There we go. I'm going to end our recording by just saying one more time, thank you so much, everyone, for coming out today. If you're looking for more Family Shade information or Parent Information Center information, you can check out both of our websites or our social media. Join our newsletter, and hopefully we look forward to seeing you again in the future on more ways to open resource gaps and create more access. So thank you, speakers, for coming today. Andrea, Corporal Kearns, we appreciate you both. I'm going to end it now, but I thank you both for coming again.
Thank you for having us.
Thanks. Have a good day.